always say is that we've come a long way with treatments for myasthenia gravis. So the name myasthenia gravis comes from grave. It was not a good thing to have myasthenia gravis, especially in the early 1900s, where mortality was close to 100%. As treatments became available, not just specific treatments, but as we developed intubation, ventilation, other treatments like thymectomy, eventually neostigmine, pyridostigmine, and plasmapheresis and other treatments, mortality has reduced. So if you look at the curves of mortality from the 1900s to the 2000s, we've come from almost 100% to close to 10%. So yes, we have lots of treatments, and I love treating myasthenia because it's something we can treat. But despite the fact that we've come a long way, what I want to tell you is that we have a long way to go. 90% of patients, so 9 in 10, will get better with treatment. If you look at case series anywhere in the world, most patients do get better. But I'm always concerned about what does being better mean, and that is different from different people. We've looked at something called patient acceptable state. Basically, we've asked patients if they're happy with their current disease state, something as simple as asking patients how they're doing. And when we looked in our site at patients with myasthenia gravis, about 40%, so 4 in 10, were not happy with their disease state. They had unacceptable disease burden. That's 40%. And you may say, well, that's only one center, but if you look across the world, this is happening everywhere. So there's a very nice large study in Sweden from last year that covers almost half the patients with myasthenia in the country, when almost half the patients were not in an acceptable state. Almost half the patients, despite having treatments and accepted treatments and standard of care, were having symptoms that were beyond what they would consider acceptable. If you look at North America, in the Myasthenia Gravis Foundation of America registry, we also see that patients fill questionnaires. They have a very nice registry where patients feel the symptoms they're having. They can do it on a periodic basis, and patients are still having a high burden of symptoms. If you look at Norway, they have very nice big study looking at quality of life. Again, large number of patients that are having non-happy. And that's a problem, because even if patients are better, sometimes we're happy that someone is getting better. Sometimes better is not being well enough. So you can be better from a disease, but if you're unable to work, if you're unable to care for your family, if you're unable to enjoy life, I would say that we're not doing as well as we could. So that's where we can certainly do much better. Dr. Silvestri talked about the side effects of treatment, and this is something we always have to keep in mind, because every time we prescribe something and when patients make decisions, there's always a trade-off between getting better and having a side effect from treatment. Sometimes a side effect may be worse for a patient than the symptom you're treating, and sometimes it's the opposite. So every time we're balancing this, and it's a very individual decision, because first, every patient is different, their disease is different, they have different lifestyles, different demands, and different comorbidities. So we always have to take this into account. But we know, for instance, that the prednisone side effects are a major concern for most patients. It's a wonderful, horrible drug at the same time, because it's very effective for myasthenia, but almost everyone gets side effects. People gain weight, people get osteoporosis, pathologic fractures, mood swings, headache, and everything that Dr. Silvestri already mentioned. We also know that any immunosuppressant therapy has increased risk of infections, and that's a problem because they can be quite severe. So we looked in Canada, in Ontario a few years ago at the populations by level, looking at thousands of people with myasthenia gravis, and we saw that patients with myasthenia had sometimes 2-3 times the risk of having respiratory infections leading to hospital admissions, shingles, and other infections compared to people without myasthenia, which shouldn't surprise anyone who has treated people with myasthenia, because we're actively immunosuppressing them. So any treatments that may immunosuppress less or are safer from that perspective would be welcome for patients. And of course, now with pandemic, people are more concerned about infections all the time, or we're thinking about these things all the time. And there's this potential risk of cancer that we really can't really quantify. So it's hard to tell patients how big or not that risk really is. So I always think about what would be a perfect treatment or a perfect drug. And the perfect treatment would be something that's 100% effective, meaning it cures the disease, basically no signs or symptoms. A treatment that works in everyone. So, you give it, 100%. That has no side effects, perfect, just in clinical trials, but also when you do post-marketing data, and that's affordable and easy to implement. And if we had this, we would cure everything, and that doesn't exist. But we would like, with new treatments, and as we move forward, is to close this gap and kind of improve this. So finding something that's more effective, that works in more groups, or find the groups in where it works better, reducing side effects, and making it accessible. And if we do that, we're going to help our patients. One thing that we sometimes forget is the patient perspective. And I think now there's interest in the myasthenia gravis community of gaining knowledge about what patients are feeling. And there's more qualitative studies where we're interviewing patients and asking them what they feel. And things are coming out, but things that I find is really interesting is what are symptoms that bother patients. And sometimes they're not the same as physicians are concerned about. So clinicians, we're always worried about admission and myasthenic crisis for obvious reasons, because those are the things that have mortality associated with them. So of course, we don't want patients to come to hospital admitted with myasthenic crisis. So we're always very concerned about swallowing issues and respiratory issues. But for many patients who are living out their normal lives, having double vision is one of the most bothersome symptoms, because it's very hard if you see double. You need double, you need your eyes to read, and it's really, really disabling. So oftentimes for us, we think it's a mild symptom, or like we may not be as aggressive treating double vision because people are not going to go to hospital and be intubated because of that. But often for patients, that is something that's quite disabling. If you think of someone who's a driver, that may completely incapacitate them for work. So sometimes we have to go back and remember what it was that patients told us that was really, really important. The other thing that patients are really bothered is the fluctuations. So if you look at the textbook Myasthenia Gravis, and Dr. Silvestri mentioned this about the fluctuating symptoms, that's really bothersome for patients, because patients can't plan their lives if they don't know how they're going to feel, no matter day to day, even within a single day, right? So you start the day with some degree of symptoms, and it might be completely different afterwards. So it's very frustrating for patients to not know what their day is going to look like, if they're going to be able to take their kids out for play, if they're going to be able to complete their day of work. So any treatment that not only makes people better, but that reduces those fluctuations and provides stability is going to be something that's going to be extremely useful for patients. Patients also feel that there's treatment inertia. So there's a beautiful paper that came out last year that's a patient-led study. So this was qualitative interviews, but the analyses were done by patients with myasthenia gravis. And patients felt that there's some inertia, that their treating physicians don't want to innovate. It's like, things are working, so why fix it if it's not broken, kind of mentality, where patients feel they're still not as good as they could be. And again, it comes to this trade-off, because as clinicians, often we don't want to risk patients having more adverse effects. We don't want to increase prednisone. We don't want to get patients at risk of an infection. But sometimes we need to, again, go back to remember what is the specific patient wants out of life and out of their treatment. And some patients will be okay, and some patients will say, you know what, I don't want this adverse effects. I'm happy I can manage my life with this degree of symptoms and fluctuations. But some other patients will feel that that is not enough, and then we need to increment. And that's where I feel that there are gaps, because with our current arsenal, sometimes we're quite limited in terms of the side effects, adverse reactions, the time of effect. So some patients have mentioned that they feel like they have wasted time when they have, I'm going to quote unquote, wasted 6 to 12 months waiting for a treatment to kick in when that treatment didn't work. So sometimes with especially older treatments, we need a full year before we see any effect, or before we don't see any effect and we say it's not useful. For that patient, it's a full year of their lives that they feel they wasted because the treatment didn't work. So again, any treatment that would shorten that time for action is something that would make patients' life better and better quality of life. And all these things will impact mental health. Patients with myasthenia gravis have higher degrees of anxiety, depression, and mental health problems, a lot of based from their physical dysfunction and all the things that I have previously mentioned. So as you can see, there are many treatment gaps. So when I think about trade-offs, and when I think about how to balance out all the pros and cons, for me, and talking to patients and doing research in patient-centered outcomes, comes to making this balancing out, making the balance more even side by side. So anything that will improve symptoms, that's more, efficacy, like symptoms are better, that fluctuations are less evident, that people can plan their lives. So on one side, we have that part covered with less side effects, hopefully, and that's faster action will really help patients move forward.
I think coming to terms with having a chronic illness is an ongoing process. Before diagnosis, I was quite confused about the symptoms, and I think there's some certainty about eventually having a diagnosis and having an answer to why your body isn't reacting the way it's supposed to react. And I think at first I felt like I was coping quite well with having myasthenia. I was still working full-time as a lawyer and trying to live my normal life. But then it wasn't until after I had a crisis, I think, that I fully understood the ramifications of having myasthenia and what would happen if I didn't take care of myself properly. And I think that's something I continue to cope with as I try to work full-time and parent small children. The days are busy and it's hard to prioritize your own health and wellness. But I understand now what can happen if I don't. But I do have to say that it is challenging having a chronic illness that is, one, extremely rare, that no one has ever heard of before. I think the challenges that I have faced have actually been with doctors that are not neurologists, which again, don't always have a lot of background with a rare neuromuscular disease. So, I'm the first patient that my family doctor has ever had with myasthenia. It's interesting going to the dentist sometimes because dentists don't always have a lot of familiarity with it, and they like to give me my cavity fillings without any anesthesia because they are nervous about me. So I try to educate the best I can as a non-medical practitioner, but it can be challenging where not everyone understands how myasthenia can impact it can impact someone. My relationship with my neurologist is important to me because my neurologist has kept me up to date with treatment options. Many myasthenia treatments have been around for a long time, so we have spoken about those over the years. But as new treatments become available, we talk about them to get a sense of why there are medications that she is suggesting for patients or is not suggesting for patients and why they would be appropriate for me or not.